First, anatomy of the prostate. Second, the T stage, which is the primary tumor. Third, the N stage for regional lymph nodes. Fourth, the M stage for distant metastasis. And finally, number 5, we'll tie it all together with clinical stage and risk.
So let's start with Section 1, Anatomy of the Prostate. We've got to map out ground zero. To really get this, I want you to picture a clean, two-dimensional map right in front of you on a plain white background. Now, all the normal, healthy surrounding tissues, like the bladder resting up above, the urethra running right through the middle, the seminal vesicles attached to the back, and the rectum located just behind everything, we're going to picture all of those in a calm, light gray color. And right there in the dead center is the prostate gland, highlighted in a bright, distinct blue. That blue zone, that is our starting point. That's ground zero.
Okay, moving on to Section 2, the T stage. The T literally stands for tumor, and here we're going to track the primary tumor's growth.
We kick things off with the earliest stage, which is T1. Imagine a tiny red dot hidden entirely inside that blue prostate we just talked about. At this stage, the tumor is so small it can't be felt during a physical exam, and it's not even visible on standard imaging. It is a stealthy little dot. And honestly, it's usually only discovered because a routine PSA blood test came back elevated, which then led to a needle biopsy.
Next up is T2. So let's watch how this builds. That red dot is now growing. It might involve half of one side of the prostate, maybe more than half, or it could even be on both sides. But here's the absolute defining characteristic of a T2 tumor. It remains strictly confined within the prostate capsule. The cancer has not touched the outer borders of our blue zone yet.
Now, T3A is a really crucial turning point. This is the breach. At T3A, that red tumor is breaking right through the outer wall of the blue prostate. In the medical world, they call this extracapsular extension. Basically, the cancer is no longer fully contained. It's making its very first move into the surrounding tissue.
Still inside that T3 category, we have T3B. This means the tumor has pushed even further past the prostate wall and is now directly invading the neighboring seminal vesicles. Remember those light gray glands sitting just behind the prostate on our map? Well, the red tumor is now spilling over into those adjacent gray structures.
And finally, for the T stage, we reach T4. This indicates the tumor has grown significantly and is now fixed to or actively invading other major adjacent organs. The red tumor is spreading into the bladder neck above, the rectum below, or maybe even the pelvic wall. It's a very clear picture of a locally invasive primary tumor.
Let's step outward now to Section 3, the N stage. The N stands for nodes, specifically evaluating regional lymph node spread.
This one is pretty straightforward. N0 means the regional pelvic lymph nodes are completely clear. Zero cancer has reached them. N1, on the flip side, means the cancer has spread into these local pelvic lymph nodes, so you'd see them lighting up red on our map. Think of the lymph nodes as a gateway. An N1 status tells doctors the cancer has officially entered the body's highway system.
Now we zoom way out for Section 4, the M stage. M stands for metastasis, and this is where we check for systemic disease.
The critical dividing line here is simply between M0 and M1. M0 means there is zero distant metastasis. The cancer has not traveled to far-off sites in the body, but an M1 designation tells us the disease has become systemic. It's traveled down the highway and planted new flags in completely distant territories.
And if a patient does have an M1 diagnosis, doctors break it down further by its exact destination. M1A means the cancer has reached distant lymph nodes way outside the pelvic region. M1B is a big one. That indicates bone metastasis, meaning the cancer has spread to the skeleton. And M1C means it has migrated to entirely different organs altogether, like the liver or the lungs.
All right, Section 5, clinical stage and risk. This is where we get the comprehensive picture.
You might be wondering, how do doctors actually use all these letters and numbers in the real world? Well, to truly understand a patient's risk profile, they don't just rely on the TNM spatial map. They combine it with two other vital puzzle pieces: the patient's PSA blood levels and their Gleason grade group, which scores just how aggressive the cancer cells are on a scale from 1 to 5. Together, TNM, PSA, and Gleason form the ultimate diagnostic trifecta.
When you combine those elements, you get what's called risk stratification, and it is incredibly powerful. Let's break it down. If you have a PSA under 10, a grade group of 1 in an early T1 or T2A stage, you sit squarely in the low-risk group. But if your PSA climbs over 20, your grade group jumps to a 4 or 5, or your tumor has breached the capsule like a stage T3A or higher, you move right into the high-risk group. Honestly, figuring out this specific risk grouping is often way more useful than just the T and M stage alone when you're deciding between active surveillance, going in for surgery, or starting radiation therapy.
Bringing everything together, the medical community lumps all these factors into final, overall stage groups. Stages I and II mean you're looking at localized disease, the cancer is confined to the prostate with lower risk markers. Stage 3 is locally advanced disease, so higher grades or the tumor is actively pushing outward. And finally, stage 4 means the cancer has either spread to the regional lymph nodes or it's made its way to distant sites in the body.
We have covered a ton of ground today, mapping everything from ground zero inside the prostate all the way out to the rest of the body.